44-year-old term female baby born to Miss XYZ, Para 2, Live 2, residing in Prem Nagar, Dehradun of non-consanguineous marriage via normal vaginal delivery at 40 weeks of gestation at SMIH. Birth weight is 2,840 grams, which is appropriate for gestational age, and the baby is in early neonatal period. Chief complaints: baby is admitted with her mother for postnatal observation. Antenatal history: she is a registered case at Doon Government Hospital, Patel Nagar. First trimester history: she conceived spontaneously and pregnancy was detected by urine pregnancy test after 1.5 months of amenorrhea. No history of fever with rash, excessive vomiting, fatigue, exposure to radiation, regular drug intake, burning micturition, alcohol intake, smoking, bleeding by vagina, any chronic illness, pain abdomen. Number of antenatal visits during first trimester is 1. Dating scan was done and told to be normal. Folic acids were taken. First dose of TD vaccine given on her first visit. In second trimester, quickening felt at 4th month of gestation. Iron calcium supplements were taken. Second dose of TD vaccine was given. Antenatal scans were done and told to be normal. No history of increased BP and blood sugar levels. No history of headache, blurring of vision, burning micturition, bleeding by vagina, and pain abdomen. Number of antenatal visits are 2. During third trimester, fetal movements well perceived. No history of leaking or bleeding per vagina, burning micturition, swelling that does not subside on rest, pain abdomen, headache, blurring of vision. No history of foul-smelling discharge. Iron and calcium supplements were taken. Antenatal scans were done and told to be normal. Number of ANC visits during third trimester are 3. Total weight gain during pregnancy is 12 kg. Pre-pregnancy weight is 59 kg and pregnancy weight is 71 kg. Natal history: LMP is 17 December 2022. EDD is on 23rd September 2023. Date and time of delivery: 23rd September 2023 at 2 p.m. Place of delivery: SMIH. Full term vaginal delivery without instrumentation. Birth order: second child. Postnatal history: gender of the baby female. Weight at birth 2,840 grams. Baby cried immediately. No history of NICU stay. Breastfeeding initiated immediately after delivery. Breastfeed given adequately on demand during day and night. Sleep for 1 to 2 hours after each feed. No formula feed was given. First urine and stool was passed after 5 hours of delivery. Passage of urine 4 to 5 times a day and stool 3 times a day. Vitamin K supplements of 1 milligram IM was administered. Immunization history: BCG, OPV, hepatitis B was given. Immunized till date. Family history: no history of hemolytic disease, liver disease, disease of gallbladder, hereditary disease in the family. No history of jaundice in sibling. Socioeconomic status: belonging to upper middle class according to modified Kuppuswamy scale. General physical examination. Date of examination.
Charul, can we go back to the history?
Yes,
we'll finish with the history and then come back to the examination. Can you get back your first slide?
Very nicely presented.
Yeah, so very well presented, Charul. So let's go through the history once, okay? And then we'll look into the examination. Fine.
Okay.
Now, this is your first slide, right? Here, what is the importance of this slide? Like, can you tell?
Yes, sir. So in this slide, I introduced first as a baby is 44-year-old, which is full-term female baby born to a multigravida mother of a non-consanguineous marriage and delivered via normal vaginal delivery, and her birth weight is normal.
Fine. That is fine. You have summarized it well. But like when you present the case, when you tell it out, it is good to say in sentence. That is how you'll have to tell it out when you're presenting. But when you put it in your slide, it is better to mention it as what is the name, XYZ, baby of XYZ, age, sex of the baby, address. Okay. So that is how you put it up in your slide, or that is how you put it up when you're writing a case sheet. But when you tell it, you'll have to tell it in a sequential manner. Fine. Now, next is what is the age? How important is age in this slide? And till what age will you tell it in terms of hours? And when do you tell it as day 4, day 5?
So till 3rd day of life, we tell in hours. And after 3 days, we tell in number of days.
Yeah, good. So till 3rd day, 72 hours of life. After that, we tell it in terms of days. And coming to day, how it is important? Like depending on the day of life, we can judge as to what can be the pathology that is occurring in the baby, correct? So if it is day 1 or day 2 of life, we can expect if it is a preterm child, RDS, we can expect. If it is a postnatal child born to IDM mother, we can expect hypoglycemia. If the baby did not cry, we can expect conversions to take place. If day 1 itself you notice jaundice, then you can think that the jaundice is pathological. Or coming to later, day 3, day 4, if we tell that baby is not feeding well, baby has lost weight, we can think in terms that baby has had dehydration. Or if jaundice comes up on day 3, day 4, we can tell that there is breastfeeding jaundice, correct? So that is how day is important. Fine. Yeah, well summarized. Next slide. Chief complaints, yeah, whatever you can, if there are no chief complaints, you can tell that the baby is here for routine postnatal care, or if you are presenting a case of neonatal jaundice, you can tell that there is yellowish discoloration, or if you are presenting the case of low birth weight, you can tell that for gaining weight for routine preterm care, the child is admitted. Fine. Next slide. Anything missing? Before you go into antenatal history, you'll have to take in detail maternal history, correct? So what all you want to take in maternal history?
So age at which she delivers, so parity.
Okay,
Also,
now I'll just summarize. Age of the mother is important. Why is age important? We can define whether mother is a high risk pregnancy or not. Age less than 16 years or more than 40 years will become high risk pregnancy. Yeah. Now coming to we were speaking of age of the mother. Age of the mother defines high risk pregnancy, and more than 30 years will be called elderly primigravida. Then you talk about consanguinity, whether it was consanguineous marriage or not. And we know 1st degree, 2nd degree, 3rd degree. 1st degree is 50% of shared genes. Then 2nd degree is 25%, and 3rd degree is 12.5%. Okay. Then next we can speak of spacing. In the maternal history, we can think of spacing. 2 to 3 years gap should be present if the mother is not primary. Fine. Next, we'll have to speak of mother's blood group. Why is mother's blood group important? Can you tell?
So, ABO incompatibility or RH isoimmunization.
Yeah. So that is why mother's blood group is important. And we'll have to ask about pre-pregnancy weight as well, because more in the 3rd trimester, we'll have to assess how much is the weight gain. Correct. And then how will the height make difference?
So if mother is short and then constitutional small, short stature babies can born.
And if mother is short, even if the mother is less than 145 centimeters, she will be at risk for CPD, correct? So there will be, again, it is a high risk pregnancy. Then we'll have to look into if we know the weight and height, from that, what will you calculate next?
So BMI.
Yeah. How is BMI important? Now comes whatever you're speaking.
So due to weight gain, if she is thin, BMI is less than 18.5, her recommended weight gain should be 12.5 to 18 kg. If her normal, she is normal.
No, I'm not asking regarding weight gain. I'm asking regarding the importance of BMI is if her BMI, if she is malnourished, if she is undernourished, then the child will be at risk of undernourishment as well. There will not be enough stores for the mother to provide to the child. So the child born will be what type of child? The child born will be IUGR. The child born can be low birth weight. Other than that, the child can have miscarriage. She can undergo miscarriage as well. Or there can be shoulder dystocia that can happen. Correct? Or if mother is at the higher numbers in terms of obese, then the child as well can be a macrosomic baby, which will lead to shoulder dystocia. Or we can suspect GDM that is taking place in the mother. Correct? And the nutritional status as such, if the mother is anemic, then the iron stores will not go to the baby. So there is higher risk of anemia in the baby as well. By the time the baby becomes 6 to 8 months, once weaning is started, then there is higher chance of anemia even in the baby, correct? That is why BMI and the nutritional status of the mother is important. Fine. Next, what is missing is paternal history as well, because age of the father as well is important, because higher the age, there is high risk of certain syndromes like achondroplasia or Noonan syndrome, correct? That will be important. Even blood group of the father is important, again for RH and not RH, but for ABO incompatibility, father's blood group becomes important, and their occupation as such is important. Fine. Then one more thing which you have to mention before coming to the antenatal history is past obstetric history. Is the mother primary?
No, sir, multigravida she is. So
since she is multigravida, you'll have to go in and ask what her past obstetric history is, correct? Because if past obstetric history, what is important? If there was an IUGR child born before, then there is high chance of her having hypertensive disease of pregnancy, again getting IUGR. If she was a gestational diabetes, child was macrosomic, or child had episodes of hypoglycemia, higher chance over here as well, correct? So you'll have to describe very briefly if it was a normal delivery, whether the child has any issues, and presently the child is doing well or not. Fine. That describe. Okay. Through that, you know the past obstetric history. Then coming to the antenatal history. Antenatal history, before you come to the first trimester, you'll have to tell whether it is spontaneously conceived or not. Next, because if there is assisted reproductive technology used, then what is the importance?
Don't know.
There are higher chance of twin deliveries taking place. There is higher chance of baby being born, IUGR. There is higher chances of congenital malformation. There are higher chance of chromosomal anomaly being taking place. There is higher chance of low birth weight baby being born, correct? So whether it was spontaneously conceived or not is important. Again, you can tell the birth order, since it is you can tell the birth order of this child. Then you can tell whether it is the case is registered or not. LMP and EDD you're further told, I guess, or if you want, you can mention it over here as well. Fine. Now coming to the first trimester history. Now, first trimester history, she conceived spontaneously. Okay, you mentioned. Pregnancy was detected by urine pregnancy test. That is not relevant when coming to newborn. That is important in antenatal care. Antenatal care over there, that might become important. Over here, as such, we don't need whether how the pregnancy was detected. Next, why did you ask regarding whatever you have asked, fever with rash, excessive vomiting? Briefly tell the important points.
So, fever with rash, I asked for torch infections.
Yeah, fever with rash, and if there was any swelling present, lymphadenopathy. That is important. Okay, so what are the infections? Torches and clap. Okay, so tell torches, clap. What does it stand for?
So
Toxoplasma, other viruses.
So O for other, just parvovirus, B19.
Yeah.
So R for rubella, C for CMV, and H for herpes simplex virus.
So you'll have to know the full importance of torches, and that can cause intrauterine infection in the child. And this intrauterine infection, the child can be born with, again, SGA baby can be born. The child might be born with hepatosplenomegaly. The child might be having rash. The child might throw convulsions because it might have hydrocephalus in case of toxoplasmosis or microcephaly. Chorioretinitis can be there. Cataract can be there if it is rubella. Correct. So the child is at so many risks if at all this fever with rash and lymphadenopathy was present. You can ask into UTI also. That also might be important. Next, burning maturation you asked. Next, you asked regarding the drug intake. What drug will you ask for?
So for Valproate, baby can have a cleft lip, cleft palate.
Okay. Drugs we can think in terms of two things. One is whether routinely what is given in first trimester.
So in first trimester, routinely folic acid is given.
Yeah. Why is folic acid given, and what is the dosage? Both are important.
So folic acid is given to prevent neural tube defects, and for folic acid prophylactic doses 400 microgram 1 month before conception and 3 months after conception, and therapeutically 4 milligram per day is given 3 months before and 3 months after conception.
Yes, good. That is given, and you'll have to know what are the drugs that can cause teratogenic effects in the child. So you'll have to know, remember at least minimum 4 to 5 drugs that causes teratogenic effects in the child. You'll have to know, like what can alcohol cause fetal alcohol syndrome, lithium can cause Epstein anomaly, so warfarin can cause what, so AC inhibitors, if you take, what it can cause, so thalidomide, what it can cause. So 4 to 5 drugs, just remember. The examiner might not ask in specific so and so drug, but they'll expect you to remember 4 to 5 drugs and you just tell it in a flow. Fine. Then you asked regarding, did you ask regarding radiation exposure? Yeah.
Yes, sir.
If you ask regarding radiation exposure, they'll ask what is the minimum radiation dose that the pregnant mother can get exposed to. So it should be less than 50 milligram. Okay. More than that, then the child is again at risk for teratogenic exposure. First dose of TD taken, dating scan done. Dating scan, if done, they might ask, if done in first trimester, what is the accuracy? Second trimester, what is the accuracy? And third trimester, what is the accuracy? In first trimester, what they look into. Second trimester, what will they look into? And third trimester, what are the aspects they look into? Fine. So you'll have to be aware of this. Next slide. Yeah, second trimester quickening, when it has to be felt, ideally.
Sir, in primary gravida, it's around 18 weeks and multigravida around 16 weeks.
Fine. Then when do you find decreased fetal perception of fetal movements, and when do you find increased perception of fetal movements? So decreased is, so there will be some neurological disorder in the child. So what do you think of muscle? I'm trying to give you clues. You are doing so well.
Hypotonia.
Yeah, so a floppy child will not be able to make good movements. So which kid will present as floppy infant or a floppy neonate?
So preterm.
Spinal muscular atrophy or congenital myopathy, they can present with decreased perception of fetal movements. Whereas increased movements will be in case of if the fetus itself is throwing a seizure, then the mother might feel as increased movements, correct? That is important. Next, anomaly scan is done. Fine, you have told. Iron and calcium supplements were being taken. When it will started iron and calcium supplements, what is the dose and till when it is continued?
So actually I forgot.
Yeah, it's okay. It's okay. Iron and calcium both are started from second trimester, beginning of the 4th month, and they are continued 180 days post-conception as well. Iron is 60 mg elemental iron along with calcium of 500 mg. Correct? Okay. And next, your whatever history you have taken for hypertensive disease of pregnancy and GDM, you can just tell out. There is no history suggestive of pregnancy-induced hypertension on GDM, and whatever you written is well and good. But since you'll have to go in a flow, you'll have to finish it quickly. You don't have to name each and every symptom. What you've written is good, but when you're presenting, you can just tell that as no history suggestive of pregnancy-induced hypertension or gestational diabetes mellitus. Fine.
Okay.
Yeah, next slide. Third trimester, what all you'll ask for in third trimester?
So leaking or bleeding for vagina.
Okay, now how is that important?
So leaking for prom baby, prom for
what is prom? You can't tell it as prom, no? You'll have to tell what it is. If there is premature rupture of membranes and if there is leak PV for more than 18 hours, then child is at risk of early onset sepsis. If the mother is having fever or if mother is having burning micturition, again, child is at risk of early onset sepsis because these are all sources of infection, correct? So that is what you're trying to ask out by asking these questions. Then next you will tell perception of fetal movements is continued, good, supplements will be continued, growth scan, whatever happens, growth scan, if there is IUGR, then again it is important. When the growth scan has to be done and when it has to be repeated will become important. Fine. And total weight gain in pregnancy is important. If the BMI is normal, total weight gain will be somewhere between 11 to 13. Okay. And if BMI is low on the lower side, the total BMI should be more than around, the weight gain should be around 16 kgs, and if the BMI is higher than expected, then weight gain should be around 8 to 10 kgs. What I was asking is, what is the definition of normal vaginal delivery?
So, normal vaginal delivery is defined as a delivery which occurs without any use of any instrumentation, no prolongation of stage of labor.
Okay, then, okay, I'll give you the full definition. Normal vaginal delivery is nothing but expulsion of the products of conception after 37 completed weeks of gestation, okay, with vortex presentation via the introitus with or without episiotomy being given, with the signs of birth being normal. This is the whole full definition of normal vaginal delivery. I'll repeat again. Expulsion of products of conception after 37 completed weeks of gestation with vortex presentation via the naturalis with or without episiotomy being given, along with signs of birth. Okay, you understood now? Fine. Next is onset of delivery, whether it was spontaneous or induced is important. Amniotic fluid color is important because if it is meconium stain, then baby is at risk of meconium aspiration syndrome, correct? So you'll have to ask the amniotic fluid color, and duration of labor, if possible, you can ask, because if there is prolonged labor and now the baby is lethargic, then we can think that there is some amount of intrauterine hypoxia being present. Or if baby throws convulsions, then we can think if there was prolonged labor, we can think that there was intrauterine hypoxia present, right? So that is why the duration of labor is important. And if there was any other significant events during labor, that as well becomes important. So that is to do with natal history. Next, postnatal history. Postnatal history, gender of the baby, fine. Whether baby cried immediately or not. If not, if mother is aware, you can ask about the resuscitation details. Over here, even like if the mother is not able to tell the UPGAR score, you are expected to know regarding the UPGAR score. Fine. So what is UPGAR score?
So UPGAR score, A for appearance, P for posture, positioning, G for grimace, A for activity, R for respiration.
You told P and A is same. I'll tell you. A is appearance, P is pulse, G is grimace, A is activity, and R is for respiratory efforts. Fine. For this, for each of the things, 0, 1, 2 score is given. So if by appearance, if the baby appears blue, it is 0. If the baby peripheries are blue, body is pink, 1, and fully pink, it is 2. The pulse less than pulse is absent is 0, less than 100 is 1, and more than 100 is 2. Similarly, grimace, if there is no response to stimulation, it is 0. If the child grimaces, makes facial expression on stimulation, it is 1. And if child cries out and coughs out loud, coughs or sneezes, it is 2. Activity, if the baby is limp, it is 0. And if there is some amount of flexion, it is 1. And if the baby is in universal flexed attitude, it is 2. And respiratory efforts, absent is 0, slow, irregular is 1, and crying, good crying is 2. Fine. Next, what is the importance of this UPGAR score and when do we measure?
So UPGAR score is measured at 1 minute and it's 5 minutes.
And when do we continue to measure at 10, 15, and 20 minutes?
So if UPGAR score is not reached to 7.
Okay, so that is when less than 5, we'll have to prolong it. And what is the importance of this UPGAR score? How does it help us? Now, imagine a baby has come out, baby did not cry, and it is limp, okay? And tone is, it is limp child. Now you give some UPGAR score at 1 minute. After that, you conduct your resuscitative efforts, and again at 5 minutes, you measure it. So by 5 minutes, baby's pulse rate has improved, baby is active and pink. Now what you'll make out? How has UPGAR score helped over here now?
The well-being of the baby.
Rather than well-being of the baby, it helps us in whatever resuscitative measures we have put in. It helps us tell whether it has responded or not, correct? So if it has responded well and the 1 minute and 5 minute UPGAR score, there will be a difference, correct? So it will indirectly let us know the neurological status of the child. That is the importance of UPGAR. And if you answer very well over here, they'll expect you to know what is the false positive UPGAR score and false negative APGAR score. There's a beautiful table given in Nelson. You can go back and read. That will become more so of theory. So we'll not discuss it over here. Fine. Next, what do you look into? Next, you'll have to look into the birth weight of the child. Birth weight was 2.84 kg. So what do you comment upon in the birth weight?
The normal birth weight is 2.
Yeah, so expected normal birth weight is between 2.5 to 3.5 kg. So this baby is having a normal birth weight. And baby cried immediately after birth. Next, coming to breastfeeding date. Gestational age, did you mention anywhere? Gestational age
40 weeks.
Yeah, that as well is important. Fine. Next is breastfeeding. Now, how do you assess breastfeeding in the neonate? First is, when do we initiate breastfeeding? Initiate it as soon as possible, to maximum within 30 minutes in case of normal vaginal delivery, and within 1 hour in case of a cesarean section. Next is adequacy of breastfeeding. So adequacy of breastfeeding, that can be measured in a subjective way and objective way. So that is how you differentiate. Subjective way, baby has to sleep 1 to 3 hours after the breastfeed, and urine output of the child should be around 6 to 8 times per day. And if the mother is feeding from one of the breast on the other breast as well, the milk has to leak out. Correct. And objective evidence is, you'll have to go measure weight of the child daily. And initial few days, or around 7 up to 10 days of life, baby can lose. Different in case of term and preterm. In preterm, up to 14 days, baby can lose. In term, around 7%, and preterm up to 10%, the babies can lose weight. Correct. If the rate of loss of weight is much more, that means the baby is not being adequately breastfed. So objectively, we can think in terms of weight and percentage weight loss. So this is how you assess the adequacy of breastfeeding. Next is urine output and stools. You have mentioned urine output, you can wait until how many hours?
So for urine output, we wait up to 48 hours, and for stool up to 24 hours.
Yes, good. And if there are any other clinical problems as well, you can tell. Next, you have commented upon immunization and vitamin K. Vitamin K dosage, you are expected to know 1 mg for more than 2 kg and 0.5 less than 2 kg. And immunization status, BCG, OPV, and hepatitis B is given. How do you give? What is the dosage and what is the site of administration as well? You are expected to know over here. Fine. Next, family history. Fine. If at all, though in our case, nothing significant has come up. Now, before going into general physical examination, it is always good to summarize whatever you have told, correct? So it is always better to have one more slide or one more, if you're writing down the case sheet, one more heading called as summary. And over there, you summarize it as dash hours or dash days old baby, boy or girl, born to consanguineous or non-consanguineously married couple with obstetric score of so-and-so, delivered by vaginal or cesarean section with birth weight of this much, whether baby cried immediately after birth or not, and if there was any significant postnatal history that you can mention, exclusively breastfed child, okay, with how much ever is the present weight, how much ever is the immunization status, and if there are any presenting complaints that you can mention. That is how you summarize the whole case over here. So overall history, how do you present the neonatal history taking newborn case? First is the demographic details, which we summarized. Next is the chief complaints. Next, you can talk about the maternal history, and under maternal history, you'll have to speak of age, whether consanguinity present or not. Obstetric score, you can speak of. Spacing, you'll have to tell. What is the blood group of the child, you'll have to tell. What was the pre-pregnancy weight, height, and BMI of the mother. What weight gain you can mention over here or in the 3rd trimester. Next, you'll have to go ask about the paternal history. What was the age, what was the blood group, and what is the occupation. Next is the past obstetric history. After that, you can comment upon antenatal history. Under antenatal history, you'll have to tell how spontaneous conception, what is the birth order, whether the child case is registered or not, and the number of antenatal visits. Next, you come into the 1st trimester. Over there, you speak of dating scan, whether the folic acid has been taken or not, history of any fever with rash and lymphadenopathy, drug and radiation, whether first dose of TD was taken. Next, in the 2nd trimester, you speak of anomaly scan, when was the quickening fed, iron, calcium, and folic acid supplements were taken or not, Then you look into whether there are any complaints as such by the mother suggestive of PAH or GDM. Fine. And next is the third trimester. Third trimester, whether growth scan was done, fetal movements were well perceived, any other risk factors which contribute to early onset sepsis is present, supplements have the continued, growth scan, and regarding the amniotic fluid, if there was early rupture or not. Next is the natal history. Under natal history, presentation, vortex or breech presentation, that is important, because if it was breech, then there is higher risk of prolonged labor or birth trauma, etc. Right? So presentation is important. What is the mode of delivery? If there was C-section, you'll have to tell the indication of cesarean section, or if not, vaginal delivery. Then the duration of labor is important. What was the color of amniotic fluid is important. Next, you'll have to come to the postnatal history, whether baby cried immediately after birth or not. What was the IUGR score? When was the baby breastfed? What was the birth weight of the child? And ask regarding the adequacy of breastfeeding. So that is how you sum up. Next comes the immunization history with vitamin K, and then family history, socioeconomic history. Fine. And summarize the whole thing in the end with the slide or write-up telling summary and whatever under whatever heading I've told before. Fine. So good job. Next, let's go into the examination of the child. You're not audible, Charul.
I'm audible. General physical examination. Date of examination is 25th September 2023. The baby is examined in stage 3 of level of consciousness. Skin color is pink and no sign of central or peripheral cyanosis. Vitals, temperature is 36.9 degrees Celsius. Airway is normal. Respiratory rate 45 per minute and is abdominal. Heart rate is 142 beats per minute. Capillary refill time is 2 seconds. Pulse felt and regular and no radial or radiofemoral delay. Anthropometric weight, birth weight is 2,840 gram and current weight is 2,783 gram. Hence has lost 2% of weight by day of life 2. Head circumference is 33 centimeter, chest circumference is 30 centimeter, length is 50 centimeter. Head to toe examination. Head is normal. Fontanelle, anterior fontanelle is open. Size is 2 into 2 centimeter. Posterior fontanelle is closed. Face no normal, no dysmorphic faces. Eye normal. Red reflex is present. Ear normal shape and size. Elastic recoil present. Nose normal. Melia present. Oral cavity and content normal. No cleft lip and palate. Skin erythema neonatorum present. Chest normal. Umbilicus central. Stump healing. No discharge seen. Genitals normal female genitalia. Back normal. No swelling. Mongolian spots present over lower back and buttocks. Extremities limbs, palm, sole, digits were normal. No pallar or icterus. Orifices all are present and patent. Systemic examination. Abdominal examination. Inspection. On inspection, abdomen is not distended. Umbilicus central. Stump healing. No discharge. No dilated veins and scar. Palpitation. No local rise in temperature. No palpable mass. Auscultation. Bowel sounds were heard. On CVS examination, S1, S2 heard. No murmur heard. Respiratory examination. Bilateral equal air entry. No added sounds were present. CNS examination. Rooting reflex is present. Sucking reflex present. Morose reflex present. Asymmetric tonic neck reflex present. Palmar grasp reflex. Glabular tap reflex were present. On musculoskeletal examination, Ortolani's and Barlow's tests were done and no abnormality detected. No club foot. Summary. 44 years.
Summary we'll see later. Come back to the general physical examination. Now, so the examination of baby itself. Now, what you're expected to know over here is when all we first of all examine the baby. Fine. So first examination is carried out as soon as the baby is born. Over there, you'll just assess the signs of life and UGR. So over there, you'll see whether the baby is term or not, whether the tone is adequate, and whether the baby is breathing or crying well. So if these points are fine, we term it as vigorous baby, and we tend to take the baby towards routine newborn care. If not, we'll have to take the baby to a temperature crib and we'll have to do the steps of resuscitation. Correct? So that was the first assessment. Now, once that assessment is done, you have stabilized the child, you have given routine newborn care. Then comes your next examination. Over here as well, still the baby is not yet given to the mother. Still the baby has not yet breastfed. So over here as well, you'll have to conduct a you'll have to just check the birth weight. You'll have to do the anthropometric measurements. You'll have to know the gender of the child, and you'll just screen for if there are any anomalies present. So what all you look for in the anomalies? You'll see whether the anterior fontanelle is present in the head, if there is any protrusion present, or if there are any fractures that is present. Ears you will see, and you will see if there are any sinuses or any pits that is present. Then you'll have to put your finger into the mouth and see whether there is cleft lip or cleft palate present. Correct? All the orifices you should see. Nasal orifices if present or not. Fine. Next, you'll come down, look into the genitalia, and if there is anal opening present or not. That is very important. Anal patency you will have to look into. And briefly, you look at the upper and lower limbs, whether there is polydactyly or not. Okay, so you'll have to briefly look at the child and see whether there are any congenital malformations or not. So this was the second examination. Third examination is the routine examination, which we do in the postnatal ward. Now the baby is shifted, baby is towards the mother's side, baby is breastfed well, baby is well clothed and comfortable. Over here, we'll have to do the whatever sequence of examination you have done in detail examination. Fine. And then you'll have to look into the Ballard's score, correct? That is the gestational age assessment of the child. And so these are the 4 to 5 different ways in which newborn examination has to be done. Understood?
Okay.
Yeah, good. Now, next was evaluation of the general physical examination. You've told stage 3. Okay, stage. What is the name of the stage 3? Whatever you mentioned. Stage of consciousness.
Pritchard scale.
Yeah, Pritchard scale. There are 6 scales, of which third stage is expected for. That is the ideal stage wherein you'll have to do the examination. Fine. Next, coming to the vitals. So vitals, you mentioned, very good that you mentioned it as temperature, airway, breathing, circulation. So TA, BC you mentioned. Now, first is importance of temperature. What is the importance? How do you measure, and when is it hypothermia?
So temperature, we measured axillary temperature for 3 minutes. We abduct the hand of the baby and place the thermometer, and then we support the hand by along the chest wall and wait for 3 minutes.
How do you keep the thermometer?
So vertically.
Vertically in the sense? Like you keep it parallel to the axilla, or you keep it perpendicular?
So parallel to the axilla.
Yeah, good. So now axillary temperature measurement, what we do, one is you can objectively see. You just, with the help of your palm, correct? You go touch the feet, and then you go touch the abdomen. So abdomen is the core temperature, and feet shows you the peripheral temperature. If both feet and the abdomen is warm to touch, that means the baby is having normal between 36.5 to 37.5 degrees Celsius. If the feet is cold but the body is warm, that means abdomen is warm, then the baby is in cold stress, that is 36 to 36.5 degrees Celsius. And if both are cold to touch, that means the baby is having hypothermia. Fine? Correct. Next is what you mentioned is axillary temperature. You'll have to keep it parallel to the axilla and not perpendicular. You'll always be asked to demonstrate how to measure temperature, and often the mistake that is made is we tend to keep it perpendicular to the axilla. So do not make that mistake. If you are asked to demonstrate, you will have to keep it parallel and keep it for a minimum of 3 minutes. Fine. Fine. And the ideal temperature to measure is always rectal temperature. And if it is rectal temperature, it is 2 minutes, not 3 minutes. Now, temperature definition, normal is 36.5 to 37.5 degrees Celsius. Then cold stress is 36 to 36.5. Moderate hypothermia is between 32 to 35.9 degrees Celsius, and severe hypothermia is less than 32 degrees Celsius. And towards the other extreme, hyperthermia is more than 37.5 degrees Celsius. Next was, again, we have lost you, Charul. Could you please connect back and share your screen? So next is you look into the respiration and respiratory rate. So normal respiratory rate of newborn is between 40 beats per minute to 60 beats per minute. So you'll have to do 1 full minute counting, because what we encounter in newborns is periodic breathing. So what is periodic breathing? Charul, could you please tell? Charul, what is periodic breathing? So periodic breathing is nothing but there will be brief periods of rapid breathing without any pauses in between, and that is actually normal in a newborn to have. So even if you measure for 10 seconds, and if the baby is having periodic breathing and then you multiply it into 6, you will tend to count it in terms of tachypnea, correct? So always you measure for 1 full minute. Okay, so how do you measure? You just look at the chest rise and chest fall. So 1 chest rise and chest fall is 1 cycle per minute. Fine. Next is you'll have to look into the heart rate. Heart rate is normal is between 120 to 160 beats per minute. Fine. So if the baby is sleeping, the lower limit of cutoff will be moved to 100. And if the baby is crying, the upper limit of cutoff will be moved to 180 beats per minute. Anything below 100 is bradypnea, bradycardia. Anything above 180 is tachycardia. Fine. And after measuring the heart rate, it is very important in newborns to look into the peripheral as well as the central pulses, because very often if we do not palpate all the peripheral pulses, we might miss coarctation of aorta, correct? Feeble pulses will be there in the peripheries. Charul, it's echoing. You connected to through 2 devices, I guess. Yeah, so palpate both the central as well as the peripheral pulses. If the peripheral pulses are feeble, then you'll have to think in terms of coarctation of aorta. And what else you will get to know? There is one more important cardiac diagnosis that you can make by palpating the peripheral pulses in newborn. Could you tell? This is by palpating the dorsalis pedis mainly. Charul, could you tell? If the dorsalis pedis is bounding, you will think that it is patent ductus arteriosus. So it is very important to palpate all the peripheral pulses along with the volume. Fine. Then you look into the rhythm, volume, character of the pulses. And next you see the CFT, that is capillary filling time. How do we look into capillary filling time? Charul, could you please
we press with the thumb on the bony surface, for example, on sternum. For 5 seconds, we count like as a 1001, 1002, 1003. And then we remove our thumb and wait for the refilling. And that should be, normally it should be less than 3 seconds.
So what you're telling is correct. You go search a periphery. You can either take the palm or sole of the baby. You go press it until 1001, 1002, 1003, 1004, 1005. And then you leave it. Again, you count back and see when it gets refilled. If it is more than 2 seconds, then it says that it is prolonged. And what does prolonged signify? If CFT is prolonged?
Perfusion.
Yeah, so what does perfusion indicate? If the peripheries are not being perfused, then what is at fault? Something needs to pump the blood for it to go into periphery, no? So if there is a shock in the child, then CFT will be prolonged. If the child is hypothermic, again the CFT might be prolonged. Fine. So these are the 2 differential diagnoses you'll have to keep in your mind. Next is blood pressure that you only see in sick child. So over here it is not that important. Fine. Next slide. You have mentioned, you have forgotten something else also in your vitals. We often tell it as the 5th vital, and it is very important as well in neonate mission. In the vitals.
So vitals.
During
Not
COVID, we all used to carry something,
the
no?
SpO2.
Yeah. So
Yes,
what is the importance of measuring SpO2 and when do we measure? You told this baby was around 44 hours of life, no?
yes,
So now when do you measure the saturation of the child and what is the importance? So it is very important that every newborn child that is born after 48 hours of life, we do one saturation testing at least. Why? What do we get to know? It very often happens that if the child might be having saturation of 94%, correct? For us to see cyanosis, if the baby's saturation should drop at least to around 85 to 90% for us to make out cyanosis. The child might have a saturation of 94%. Okay, so that still means that child is hypoxic, correct? So we might miss out on very important CHDs, or since the baby is still having the transition, the circulation is still in the transitory mode, the disease might not have manifested it fully, correct? So for us to pick it up at an earlier stage, we should always measure saturation. And which limb do we measure saturation?
So
it is the
right.
preductal saturation that is important. So the right upper limb we measure and one postductal, either left upper limb or the lower limb. Fine. Ideally, all the four we'll have to measure, but we'll have to see the preductal, right upper limb, and one postductal. And if the saturation is less than 95% in, or if the difference between preductal and postductal saturation is more than 3%, then we'll have to make them undergo a 2D echo and screen for any congenital heart disease if present. Fine. So that is the importance of vitals. Next was what? Anthropometric, correct? So show the anthropometry slide. Yeah, birth weight. Birth weight should be measured within 24 hours of life. Good. What is the normal birth weight? We already discussed. It was 2.5 to 3.5 kg. So how do you define low birth weight?
So low birth weight is defined as weight less than 2.5 kg.
Yeah, and how do you categorize them?
The low birth weight baby, extremely low birth weight baby, very low birth weight baby.
Yeah,
very
tell
low
the
birth
weight category as well.
So very low birth weight is less than 1.5 kg, and extremely low birth weight babies weight less than 1 kg.
Yes, very good. Fine. And based upon the weight, we'll go plot it, right? So on which chart do you plot the weight?
So WH chart, sir,
Okay,
intrauterine growth chart, that is
fine. I'll explain it to you. This was partly difficult question, I understand. So the growth charts that are there are two types of growth charts. One is intrauterine growth chart, which is used to monitor the intrauterine growth of the child, and one is the postnatal growth chart. Fine. If it is a term baby, then postnatal chart, what you told is correct. The WHO MGRS chart is used. If it is a preterm baby, then what you can use is the Ehrenkrantz chart. It's called as Ehrenkrantz chart, or the Intergrowth 21 chart, which has newly come up. Those are the charts which we can use and plot it. Weekly basis, we'll have to plot and see the growth of the child. That is how we look whether the low birth weight baby is growing well and whether it is having adequate weight gain as well. Fine. And the intrauterine growth charts for the low birth weight babies is important to see whether the gestational age of the child is appropriate or not. Over here, we'll go and plot it in the Fenton's chart, what you mentioned, correct? So over there, if it falls less than 10th centile, it is called as SGA baby. If it is between 10th and 90th centile, it is called as appropriate for gestational age. And if it is more than 90th centile, it is called as large for gestational age babies. Fine. And next, as we already discussed, the weight loss up to 7 to 10 days in term babies and up to 14 days in case of preterm babies, they'll have to regain their birth weight. So initially it is 5 to 7% in term and around 10% in preterm. Fine. 10 to 15%. Fine. Next is the length. So what is the normal length?
So around 50 centimeter at birth.
Fine. And how do you measure length?
So by the infantometer.
What infantometer it is called?
So two people are required. One is to stabilize
the name of the
head
infantometer.
Yes, sir.
It is Harpendon's infantometer. How do you measure?
So with two people are required to measure the length of the baby. One to fix the head of the baby to the stable part, and one is used to extend the legs of the baby and move the other flexible board.
Yes, good. So we'll have to, there will be an infantometer that is kept in the examination hall, and we'll have to see how we'll have to show them as to how the length is measured, and what you told is correct. And weight, what I forgot to mention is, very often the mistake is made that we check the weight with the cloths, correct? As the infant itself weighs around 2 to 2.5 kg, the cloths will add up to another 100 grams. And if this 100-gram weight loss will become significant in terms of percentage loss, correct? Fine. So we'll always have to undress the baby and then measure the weight. And weight is measured using a digital weighing machine. Fine. Good. Fine. So we know the weight of the child, we know the length of the child. Next is head circumference. When do we measure head circumference of the child?
So after 24 hours of life.
Why? Because until 24 hours of life, the child has just now, you told that it is a normal vaginal delivery. So how does the child come out? That there is so much, if there is vertex presentation, there is so much pressure that is put onto the child's head, right? So there will be some amount of molding, there will be some amount of edema that is present. For all those things to resolve and for us to get an actual idea of the true head circumference, it takes around 24 hours. Fine. So it is after 24 hours we measure. And what is the method called head circumference? What is the method?
So cross tape method.
Yeah, cross tape method. How do you measure the head circumference?
So we measure head circumference with the help of the measuring tape. We measure from the occiput to the front to the above. So
it is the maximum occipitofrontal circumference, correct? So we take the measuring tape. It has to be cross tape. That means it shouldn't be matching the edge to edge. It should always be crossed, correct? So we'll have to always cross it, keep it on the temporal side. Maximum behind is the occipital protuberance. In front is the supraorbital ridges. So go through the head, through the supraorbital ridge, occipital protuberance, and measure it over the side and make sure it crosses. Fine. And we should always take 3 such measurements. Fine. And then after taking the 3 such measurements, take the maximum value that you got as the actual head circumference. Next is chest circumference. Chest circumference, how do you measure? At what level do you measure the chest circumference?
So at the level of the nipples.
Yes, very good. At the level of nipples or at the level of the 4th interclavicular space, you measure into the space between the ribs, you measure 4th and 4th intercostal space. Fine. So now what is important is the ratio between the head circumference and chest circumference, and how is that important?
So head circumference is more than chest circumference. Difference is 3 centimeter at the time of the birth, and by the 1 year the head circumference is equal to the chest circumference.
No, it is partly different. At birth, head circumference should exceed the chest circumference by 3 centimeter. By 9 months of age, we expect head circumference to be equal to chest circumference, and by more than 1 year, the chest circumference exceeds head circumference. If this doesn't happen, then there is some amount of malnutrition that is present, so the baby is not growing well. That is the importance of head circumference and chest circumference. Fine, correct. Next, what you're expected to know is, we have done the charts, we have done the anthropometry. How does the baby grow? What is the normal weight gain of the child? How is the baby? What is the, like now the baby is born, the baby comes to follow up at 1 month of life. So what do you assess? You assess the weight of the child, correct? At that point of time, what is the expected weight gain you see?
So during the...
Okay, fine. I'll tell it to you. So weight, length, and head circumference. So we divide it as 0 to 3 months, 3 to 6 months, 6 to 9 months, 9 to 12 months, and 1 to 3 years. So weight is 30 grams, 0 to 3, 20 grams per day is between 3 to 6 months. So it is 30, 20, and 15 grams per day between 6 to 9 months, 12 grams per day between 9 to 12 months, and 1 to 3 years, it is 8 grams per day. So it is 30, 20, 15, 12, and 8. So that is how weight gain is supposed to occur. Next is length. How do you expect the length to increase? So in between 0 to 3 months, it is 3.5 centimeter per month. So between 3 to 6 months, it is 2 centimeter per month. Between 6 to 9 months, it is 1.5 centimeter per month. 9 to 12 months, it is 1.2 centimeter per month. 1 to 3 years, it is 1 centimeter per month. So it is 3.5, 2, 1.5, 1.2, and 1 centimeter per month. Fine. Next is head circumference. Head circumference is 2 centimeter in the initial 3 months, 1 centimeter per month between 3 to 6 months. Between the 6 to 12 months, it is 0.5 centimeter per month, and 1 to 3 years, it is 0.2 centimeter per month. So this is again one of the very frequently asked Viva question as to how the baby is supposed to grow. And practically as well, it is very important, because when the child comes to you for follow-up, to assess the nutritional status and to assess whether the mother is breastfeeding or not, we'll have to look into the weight. We'll have to look into the length, and to assess the neurological status of the child, we'll have to look into the head circumference. Fine. Good. Next. Over here only, if at all it was a low birth weight baby, what else you would have calculated? What index you would have calculated?
The ponderal index.
Yeah, ponderal index. What is the formula?
So weight in gram divided by height in centimeter cube.
You call height. When do you use the term height in pediatrics?
So after 2 years of age.
Yes, very good. So until 2 years, we'll have to use the term length. Okay.
Length.
So ponderal index, weight in grams divided by length in centimeter cube into 100. If it is less than 2, it is asymmetric IUGR. If it is more than 2, it is symmetric IUGR. Fine. And SGA and IUGR is used interchangeably, though there is a difference that exists in the definition, but that is not for your level. So you can either tell SGA baby or IUGR baby. Now coming to IUGR baby, what is symmetric IUGR? What is asymmetric IUGR?
So symmetric IUGR, if babies have growth restriction same all over the body, and then asymmetric, brain sparing can be seen. Brain grows normally and other parts of the body grow restrictedly.
Yeah. So in case of symmetric IUGR, what happens is the insert takes place in the initial 3 months of life. Fine. So the whole organogenesis gets affected because all the organs are formed in the initial 3 months of life. Correct. We spoke of in the first trimester, we spoke of the mother being affected with tortuous infection. Correct. If mother B gets a tortuous infection or intrauterine infection, what is the type of IUGR you expect then? It is in the first trimester. So organogenesis is affected. So you expect what?
Symmetrical.
Yes, very good. So you expect symmetric IUGR. Whereas asymmetric IUGR is when in the second trimester, what was one significant history you asked in the mother? What was it?
The uteroplacental insufficiency.
Yes, very good. You asked for hypertensive features of hypertensive days of pregnancy. If in case preeclampsia develops, there will be uteroplacental insufficiency. Again, blood supply to the baby is not enough to match with the growth of the baby. So there will be growth faltering. That is why you do growth scan as well in second trimester, correct? Not in second trimester, in third trimester, you do growth scan and you plot how the child grows, correct? That is to look into, again over here, asymmetric IUGR. If after first trimester, second and third trimester, if it gets affected, then it is asymmetric IUGR. Fine. That is the important. In asymmetric IUGR, head continues to grow, but the body falls back. Okay. So in symmetric, head and body both are affected. In asymmetric, head continues to grow, but body gets affected. Okay. So symmetric IUGR is more than 2 and asymmetric IUGR is less than 2. Did you understand? Okay. Next. Let's go. Yes. So more than systemic examination, what is important for us is the head-to-toe examination of the child. First one, still over here as well, we still have to look into pallor, icterus, cyanosis, if it's present, right? Is it important? Pallor, if the baby has had RHSO immunization, baby would have had hemolysis, baby looks pale. If there is a significant amount of hypothermia, peripheries looks pale to us, correct? So pallor is important. Next is cyanosis. Cyanosis, we already saw the importance, and that is why we do the pulse oximeter testing as well. What if you find just the peripheries are cyanosed? Is it okay to have something like that?
The acrocyanosis.
Yes, good. So it is okay to have acrocyanosis in the initial few days of life, or the child is having cyanosis of lips and the tongue as well. It more than the lips, it is the cyanosis of the tongue that is important. Then we tell that the child is having central cyanosis. Baby is having central cyanosis, and you measure the saturation. Next is very important is to look into icterus. How do you measure icterus? Or sorry, how do you examine icterus?
So first we in the face we see, then
in the face, do we see in newborns?
cephalo-
Is it easy to examine the eyes of the newborn? No, right?
No, sir. In the face we see.
Okay, fine. Next, how do we examine for icterus as such? In face as well, it is difficult to make, no, because most of the times the room will not be so well lit. Correct?
So
Most
by
of the times they would have put on all the
skin.
clothings over the baby. So what do you do? Or in the face itself, where do you see?
So on the forehead.
Yes, good. So in the forehead, what do you do to see?
So by we blanch the forehead skin.
Yes, very
And
good.
then
So we go either over the sternum or over the forehead. You blanch the skin and then just slide it apart, correct? With the help of your thumb. Okay, once we move apart, stretch the skin like that, under sunlight, we'll have to take it into the well-lit area, press the bony prominence either over the forehead or the sternum and blanch the skin. And you will find icterus. More easily, it is visible. And now what is Kramer's rule?
the modified Kramer's rule, zone 1 in face it is 5 to 7, and
Where
then
is
in
zone
upper
1?
trunk it is 7 to 9 milligram per deciliter, and in lower trunk and up to the thigh it is 9 to 11. Sorry,
Good.
11 to 13.
9 to 11 only.
9 to 11, and in
This is zone 3, so it is 9 to 11. Zone 4 is legs and arms and forearms. It is 11 to 13, and more than 13 is palms and soles. Okay, good. Next is edema might not be that evident if there has been prolonged labor, if the baby has had intrauterine fetal hydrops. In such cases, you might find edema. Okay, next is the proper head-to-toe examination. Head, what all you look in the head, you look at the distribution of hair. Then very important is you go palpate the fontanelle. Normal size is 2 into 2 centimeter. How do you measure anterior fontanelle length? How did you measure over here? 2 into 2 centimeter.
Then we measured by the edges of the wall to the opposite.
In the sense, you can just show it to me. This is the anterior fontanelle, no? So how do you measure now? You can show it.
By not
Yes.
diagonally, it is measured by the edges.
Good, correct. So this is the anterior fontanelle. From here till here you measure, correct? You go like this and like this. It is not at the corners. Fine. That is important. Normal length is 2 into 2 centimeter in a term baby. It can go up to 3.5 centimeter in a preterm child. Fine. So when do you expect the fontanelles? Like, okay, first question is how many fontanelles are present in a newborn?
So total 6 fontanelles are present.
Correct, good. So where all? Coronal?
So one is anterior, posterior, anterior-lateral, two pair of anterior-lateral, and a pair of posterior-lateral.
Posterolateral. Fine. So anterior fontanelle, we know the measurement. When do you expect the anterior fontanelle to close?
So by 9 to 12 months.
9 to 12 months, huh? That became quite earlier. It is between 12 to 18 months. Okay, so when do you expect delayed closure, and when do you expect the anterior fontanelle to be larger in size?
The increased intracranial pressure,
That is bulging anterofontanal, what you're speaking of this. So bulging anterofontanal, in case of neonatal meningitis, it might be bulged. And depressed anterofontanal, if the baby is dehydrated, there might be depressed anterofontanal. What I'm asking is large anterofontanal. It is measuring around, a newborn comes with 4 centimeter anterofontanal, 4 into 4.
The anencephaly.
No, it is a very common occurring. This almost, there is 1 to 2001 per 2000 child is the incidence of this disease.
The Down syndrome.
Mhm.
I don't know.
Okay, Down syndrome is one of the cause for like this thing. So Down syndrome, or if there is congenital hypothyroidism, there will be large fontanel, or there is achondroplasia, or there is hypophosphatemia. These are the causes for large fontanel. Delayed closure as well. Again, rickets can be a cause for delayed closure. Again, congenital hypothyroidism may be a cause for delayed closure. Posterior fontanel. How do you palpate for posterior fontanel? It is
So
using
it is
the
a fingertip.
Yeah, little fingertip. Okay, so you palpate. Okay, very smallly it will be palpable, almost around 0.5 centimeter. And when do you expect that to close?
So by 3 months.
6 to 8 weeks, it has to close. And posterior fontanel being patent is characteristic for, again, congenital hypothyroidism. So anterolateral and posterolateral closes by around 3 months to 1 year, it closes. So for fontanel, you check the measurement of the fontanel. You'll have to know when it closes. You'll have to know what are the causes for bulging fontanel, depressed fontanel, large fontanel, and delayed closure. Okay, so head is over, anterofontanel is over. Then you come to the ears. Ears, you again see external ear. If there is any malformation of the ear, if there are any pits or sinuses present, and if present, you'll have to do a USG abdomen and 2D echo to look into the associated malformation. Eyes, what do you see then? First of all, have you examined this newborn?
Yes, sir.
So was the baby's eyes open when you examined?
So eyes are closed. And
Then how do
at
you
the
make
end of the examination, baby wake up.
Okay, in case it is in stage 3. Stage 3, you don't see often that the baby is just awake, no? So baby might not open its eyes. Then how do you make the baby's eye open?
So by
Baby will be sleeping around
gently shaking the baby, or by the lifting the head of the baby.
No. Then you'll again cause trauma to the baby, no? It is still a newborn child. It is very fragile. What you do is you just sway the baby. Okay? So you just sway the baby. Once you sway the baby automatically opens its eyes. Fine. And now you find a subconjunctival hemorrhage being present. What do you do that time? Or the parents might come to you telling, doctor, see, my child's eyes are red. You are the pediatrician in charge. What do you counsel? How do you counsel the parents?
It's normal to have.
Yeah, it is normal to have. Correct. So now what I'm coming to the point is, what are the normal findings that the parents might presume it to be abnormal and come to you, and you just counsel telling it is a normal finding. So what are those findings?
The melia, erythema, neonatorum.
No, in the eyes I'm speaking of.
Then I don't know.
So retinal hemorrhages is common to have. Conjunctival hemorrhage is common to have. The child might have some amount of strabismus. That also is common to have. Child might have nystagmus as well. This is all I'm speaking of is a newborn baby. If it is present beyond 5 to 6 months, all of this becomes pathological. Okay. Strabismus, nystagmus, and all. In the newborn baby, all these things are normal to have. So that is what you examine in the eyes. Next, you come to the nasal bridge. If whether nasal bridge any deformity is present, you look into the nose. Okay. Now, okay, fine. The next situation I give is the baby is trying to breathe through its mouth. Then what do you say? And on crying, the baby appears cyanoid, and on crying, the baby becomes pink. What can you think of? We all can breathe through mouth, right? But usually what we see is the neonates are obligatory nasal breathers. Okay. So if this has to happen, the nasal cavity should not be patent. So what am I hinting at? it is an emergency also. You'll have to treat the child immediately. What I'm talking of is choanal atresia. Correct? There will be newborn will come, it will be breathing through mouth, it will be cyanosed, and on crying for feed, it will become pink. So this is the classical scenario of choanal atresia. So that is important to look into the nose. Then coming to the oral cavity, again, you'll have to wear gloves. You'll have to do a proper, put your little finger inside and properly look for cleft lip and cleft palate, because most often there might be a submucous cleft palate or soft palate cleft, which will be missed, correct? So always put your mouth in, put your little finger inside and examine, and also examine with a torch what you will find, what is the normal finding that you can, normal finding that you see in the oral cavity. Epstein pulse is normal to have, natal teeth is normal to have, correct? And one more important thing I forgot is in eyes, red reflex. What is this red reflex that you have mentioned?
The red reflex is used to check for cataract or corneal opacities.
Is red reflex normally present or not?
So it is normally present.
So what is red reflex is, it just like how we do saturation SpO2 monitoring for every kid, red reflex as well is a mandatory screening test that we do to all the kids. Okay. So what we find is, with the ophthalmoscope on directing red light towards the eyes, if red reflex is seen, if it is red in color, that means the light is easily passing on through the eyes. If it is white reflex, that means the child might either is having a cataract, or the child is having retinoblastoma, due to which leukocoria is present, and the child needs further examination. Okay. So it is red reflex, which is normal to have, and white reflex that is pathological and needs to be identified. And if we don't treat it at the earliest, the child might become blind. Cataract is easily treatable in a newborn, correct? If we go operate it, we can treat and we can save the vision. Retinoblastoma, if present, again, if we give the required chemotherapy, the child is salvageable. The baby is very much salvageable, correct? So it is one of the very important things to look for. So we finished, and then as a whole overall face, we'll have to look for if any dysmorphology is present or not. Next, you look into the chest, you look into the nipples. It is normal to have what we call some amount of breast milk that is coming out of the nipples. That is because of the maternal hormonal effects. Along with it, it is normal to have even some amount of vaginal discharge as well, or blood coming out of the vagina as well, up to 7 days of life. That is also because of estrogen influence in the mother's estrogen influence in the child, in the newborn baby. Next, you look at the chest, whether any deformity is present. You look into the nipples. If any accessory nipples or extra nipples are present, that as well you'll have to mention. Next is umbilical cord. Umbilical cord, what do you see?
So that it is centrally placed or not, and for two arteries, for arteries and veins, we see.
Yeah, so two arteries and one vein, if present or not, we look into. And if there are any anomaly present in the umbilical cord, we'll have to again, more than one arteries, more than two arteries are present and all, we'll have to look into again USG abdomen and 2D echo to look into associated defects. So umbilical cord is over. Then you look into the genitals. Then if male, you see whether both the testicles are palpable. If female, you look in the genitalia, examine. Then you have to look into the anal patency, limbs and spine. Finally, coming to the skin. Skin, what is important and what are the transient phenomena that you see in the skin?
So, erythema, neonate, we can see.
You'll have to know minimum 5 to 6 transient neonatal phenomena. Okay, you will be asked to name. That is again theoretical, so I'll not go in detail, but you'll have to know minimum 5 to 6 transient neonatal phenomena like erythema neonatorum, or Mongolian spots, or Epstein pulse, or stroke bite, which you can have over the forehead. Fine. So you'll have to name 5 to 6. Next is the last is the spine and the back, which you will have to examine to look for any myelomeningocele, or if there might be any sacral dimpling that is present. If sacral dimpling, or if sacral lipoma, or any swelling near the sacrum, or if there is any tuft of hair that is present, again you'll have to do in detail examination of the spine, and you'll have to do an ultrasound of the spine and MRI as well to look into the any neural tube defects that is present. Okay, so that was to do with the head to toe examination. Next is systemic examination. Systemic examination, abdomen, what all you see in abdomen?
So that distension, dilated veins, there is any
So
discharge.
you don't have to do it in so much detail. You just do a simple inspection. You look at whether the counter of abdomen is present, whether there is any abdominal distension in the initial few days of life. If it is abdominal distension with vomiting, we'll have to suspect bilious vomiting, some intestinal obstruction is there, correct? Or if there is scaphoid abdomen that is present, you'll have to think of a CDS that is present, correct? And you can do a auscultation for bowel movements and see, and just do slight palpation, okay? That much to do with the abdomen. So inspection, you look at the contour, you look at whether there is any visible veins, you look at any abdominal distension is present, and mildly palpate, look for any organomegaly if at all it is present, and auscultate for bowel sounds. That was to do with abdomen. Next is CVS. CVS, you missed something very important. Can you tell what it is? So CVS, again, the inspection part is the same. You look into the apex pit, you look whether trachea is centrally placed, you look for any other pulsations that is seen. Fine. That is in coming to the inspection. Next is auscultation. So what is it that you will have to look into in auscultation?
The murmurs, innocent murmurs.
Fine. So there is S1 and there is S2. S1 happens due to what? It is because of closure of the mitral and the tricuspid valve. So S2 happens due to what? Closure of the pulmonary and the aortic valves, correct? So do they close at the same time or do they close at different times?
So at different times.
Yeah, so A2 closes first, followed by P2, correct? So in neonates, what is very important is to hear a split. Okay, so S1 and S2 heard along with split, because split is almost by day 3 of life, almost 90 to 95% of the babies should have split by 72 hours of life. So if there is split, A2 and P2 split, you'll have to examine it very carefully, because the heart rate will be around 140 beats per minute. No? So you'll take your time, take 1 to 2 minutes and examine it. So you will hear a split, because if the split is present, it indicates that the septum is present, the two ventricles are functioning properly, the aortic region and the pulmonary region, blood is flowing adequately, correct? So if at all these things are happening properly, it indicates that there is no other underlying congenital heart disease that is present. Fine?
Yes, sir.
So if you don't appreciate split, then you'll have to think that there might be some pulmonary hypertension is there, or TGA is there, or aortic pulmonary valve atresia is there, or a truncus arteriosus can be there. Fine. So this is the importance of split. So S1 present, S2 heard with A2 and P2. That is how you are supposed to tell. Now coming to murmurs. So in newborn, is it routine to hear murmur? Is it like normal to hear murmur, or is it pathological?
So sometimes normal, just like innocent murmurs can be heard normally.
Yeah, it is like you can very frequently hear murmur in a newborn, because what will be happening is still the transition is taking place now from the fetal circulation to neonatal circulation. So you might hear a closing PDM murmur, or you might hear a small flow murmurs along the valves. Okay, so it is normal to hear. Like what is said that out of 13 murmurs, 12 out of 13 murmurs are normal in newborns to have. So these are called as what? You just now mentioned it. Innocent? Yeah, innocent murmurs. So what are the features of innocent murmurs? Could you tell? So innocent murmurs are soft. So it will be just 1/6 or 2/6 grade murmur. Fine. There will be no added clicks or ejection snap, all those things. Opening snap or ejection click will not be present. Pulses on palpating will be normal. Such a cyanosis won't be present. And the newborn that is born will be very much healthy. Okay. And if it is a pathological murmur, then it might be a large grade, like 3, 4, 5, 6 grade murmur, or if there is cyanosis present, or any grade diastolic murmur, okay, or pansystolic in nature. So all these things will indicate that harsh quality of the murmur, you will indicate that it is a pathological murmur. Okay, so these are the important things. Now, next, what they'll ask is, in the first week of life, what are the normal congenital heart disease that can present?
So the patent ductus
Yes,
arteriosus.
good. Okay, PDA, if it is hemodynamically significant, a patent ductus arteriosus can come. Which cyanotic heart disease can come?
The
If there is
tetralogy
transposition of
folate.
greater, all the T series, no, whichever starts with T, TAPVC, transposition of great arteries, truncus arteriosus, all these things can come in the first week of life. Fine. So next system is respiratory system. Fine. Again, the routine inspection you see, and then you auscultate. If there are any added sounds, you see. If there is grunt, what are the abnormal sounds that you can hear?
The grunting, wheezing,
Yeah, what does grunting mean?
stridor. Yes, sir.
What do you mean by grunting? Is it normal to have grunting, or is it pathological, or is it a very serious condition? What is it?
So it's
Grunting means
pathological.
what is happening is, okay, now we take a situation of a preterm newborn. So what is the common respiratory disease that a preterm newborn can have because of deficiency of surfactant?
The myelin.
Yeah, hyaline membrane disease
disorder.
or the RDS can be there. No,
Yes.
so what happens is, that time complaints of the lung won't be there because of the lack of surface tension. The alveoli collapses. Correct. So once the alveoli collapses, the lungs has to generate its own positive pressure to open up the alveoli. Correct. So what it does is, against the closed glottis, it tries to push away the air so that positive pressure is maintained and the collapsed alveoli, what is there, can open up. For this to happen, grunting is produced. Okay, so it is quite a serious condition to have if grunting is present. So what are the other signs of respiratory distress?
The nasal flaring, bowing of head, retraction.
So chest retractions, you look for, tachypnea you look for, and all these other pathological sounds like grunting, stridor, all these things you can look for. Fine, so inspection and auscultation. This also you don't have to do it in details, you can just mention. Next, coming to the CNS examination. One more thing which we missed in head-to-toe examination, I think so, is for developmental dysplasia of hip, what do you see? What are the two manuals that is done?
So Ortolani and Barlow's.
Yeah, so Barlow's is what, and what is Ortolani?
The Barlow's test, we abduct first we place the thumb over the medial aspect of the thigh and the middle finger on the greater trochanter, and then we abduct the hip, adduct the hip, and we look for any click. If there is a click present, then
so you adduct the hip this way, you keep the thumb on the medial aspect, and you keep the other fingers over the buttocks and you adduct it. If it is dislocatable, it is Barlow. Once you fix the dislocatable hip, it is called as the Ortolani manual. So dislocating is Barlow, fixing back is Ortolani. Fine. Good. Next, coming to neurological examination. So first is, again, you'll have to mention the state of consciousness. Over here, it is again given by Prechel's scale. Stage 3 is the ideal stage to measure. Next is, you'll have to comment upon the activity of the child or behavior of the child and how the cry of the baby is. Why it is important is, the normal newborn, once it is born, for initial 2 to 3 years, it is irritable because the surrounding environment is new. It is not used to it. Once it gets used to it, it sucks onto the mother's breast and slowly goes on to the sleeping. It sleeps for 2 to 3 years, gets up, sleeps for 2 to 3 years. And initial few days, baby sleeps for around 20 hours. And slowly this reduces. So this is the normal behavior of a newborn child in the initial first week of life. And first 2 to 3 days, they tend to sleep more in the day as compared to night. So usual complaint in the first 2 to 3 days, the parents get the children to assess the baby is not sleeping in the night. Correct? Why? Because it is still not yet adjusted to the circadian rhythm. So this is the usual behavior of the child, which you'll have to explain. And whether the cry, if it is present, consolable or not. And if there is high pitched cry present, that it indicates that, early onset sepsis,
XI.
meningitis has taken place, and cerebral irritability it indicates. So that is to do with the cry behavior. And then you'll have to go tap over here and see whether habituation is taking place. After 3 to 4 stimuli, still habituation is not taking place. Then again, it indicates some neuropathology is present. Fine. Cranial nerve, you just briefly examine all the facial movements and mention grossly it is normal. What you missed over here is the motor system examination. Motor system examination, again, you look into the posture of the child. If it is universally flexed attitude, that is it is flexed over here near the elbows. It is flexed near the legs are abducted and flexed near the thighs. That means it is the universally flexed attitude. So that is between 30 to 40 weeks. That is the actual posture the child, baby, newborn baby should be. If not, what is frog-leg posture?
The hypotonia.
If there is hypotonia, the child's leg will be fully adducted and touching onto the floor. That again happens in spinal muscular atrophy or congenital myopathy, correct? So that is why posture is important. Next is tone. Tone you examine by, how do you examine tone? That is what you call it as the 180-degree flip test. Initially, you will have to hold on to both the arms of the child and you will have to pull the child. Okay. If it is fully floppy, the head will lag behind totally. Or else initial head lag followed by the head will follow the baby's body. Fine. Next, vertical suspension if you do. And if the baby slips over, that means again there is hypotonia present. After that, you hold it in vertical suspension. Again, in vertical suspension, if the legs fall over, heads fall over, then again there is hypotonia, correct? So this is the 180-degree traction, vertical suspension, and ventral suspension. 180-degree flip test which you do. Next is the deep tendon reflex, and only deep tendon reflex that is seen is the patellar deep tendon reflex. Fine. After that, primitive reflexes you have mentioned. Good. So what is important in primitive reflexes? The 4 basic reflexes: palmar grasp, rooting reflex, and you'll have to show us how the reflexes are elicited as well. Rooting reflex, you just stroke onto the side of the mouth, the baby turns. Sucking and swallowing reflex, you see it by the way the newborn baby breastfeeds. The sucking and swallowing will be coordinated. Next is Mora's reflex. How do you elicit Mora's reflex?
So we lift the baby by holding his hand, and then we allow the baby to fall, and we can support the back of the baby. And then firstly, the extension and abduction with opening of hands, then followed by the flexion, adduction, and closure of the hand, along with the baby can cry.
Yes, very good. That is Mora's reflex. Next is ATNR. How do you demonstrate ATNR? Asymmetric tone
So when we turn the head of the baby, and on the turned side of the head, the baby's extend his extremities, and
on the opposite side, baby will flex.
Flexion.
Good. Then how do you elicit palmar grasp? You
so for palmar grasp, we put the little finger on the from the ulnar side of the hand of the baby.
Yes, good. And the baby will grasp onto it. Now, what is one more important point is, when does the onset take place? When it is fully developed and when it disappears. Like if it is ATNR, its onset is around 35 weeks, fully developed around 1 month, and it disappears by 6 to 7 months, so that the rollover of the newborn baby, the infant, can take place. If it is Mora's reflex, it starts at 28 weeks, fully develops at 37 weeks, and disappears by 5 to 6 months of the infant's life. If it is palmar grasp, 28 weeks it comes, around 32 weeks it is fully developed and disappears by 2 to 3 months. Okay, so you'll have to know when it comes, when it is fully developed, and when it disappears. So the minimum reflexes that you will need to know is rooting reflex, sucking reflex, swallowing reflex, palmar grasp reflex, Mora's reflex, ATNR. Okay. So fine. Next is musculoskeletal. Okay, you mentioned musculoskeletal, you mentioned Waterlani and Barlow's. Fine. What else you'll have to see? before summary, there is one more important aspect that you'll have to see.
So,
Gestational age assessment you'll have to do, no?
Ballard.
Yeah. So what is Ballard score?
So extended Ballard. So it contains physical and neurological parameters. In physical, we check for arm recoiling, scarf sign, popliteal angle, shoulder window, wrist, and in neurology. And in other, we see for skin, lanugo,
Yeah, okay, fine.
genitalia.
I'll tell it to you briefly. So what we do is called as the new Ballard score. The scoring starts from -10 to 50, with -10 being 20 weeks period of gestation and 50 being 44 weeks period of gestation. There are 6 physical signs and 6 neurological signs that you see. And you'll have to know how to elicit all the 6 the physical signs. First one is the posture. Posture we saw, no? The universal flexed posture is normal for a term child. Next is square window. You take the baby's arm like this and you flex it. Okay, this is square window. Arm recoil is you extend the arm of the baby, hold over here, leave it onto the bed, and leave your finger and see how much will be the recoil of the arm. Popliteal angle is you flex onto the hold your finger over the popliteal angle and you try to extend the knee and see the angle that is created. Scarf sign is you take the elbow, this should go towards the opposite shoulder and see whether it crosses the midline of the body or not. That is the scarf sign. Heel to ear is you go press it at the hip joint and then try to extend the knee and see until where you can extend. So if there was a newborn baby available, it would have been easier to show. Or we have already conducted a class on newborn examination. There is a separate section called as neurological examination, wherein all these signs have been demonstrated. You can go have a look at that as well. Next is physical sign. Physical sign will include skin, then it can include lanugo, then it can include the plantar surface, and then if the breast, whether the nipple and the buds have developed, eyes and ears, and genitalia of both male and female. So these are the 6 neurological and 6 physical signs that you'll have to remember. Fine. So now you will be summarizing your case. So final summary will be this: what you've done over here should have been present at the end of your history. And over here, finally, provisional diagnosis. What you write over here is this is a term child, term baby born by normal vaginal delivery, appropriate for gestational age for routine newborn care. Term gestation, appropriate for gestational age, for present for routine newborn care will be your provisional diagnosis. Okay, so now you've done all this part and you've declared that the newborn is normal, right? Now, can you tell like what is the definition of normal newborn?
So like what? So a healthy newborn is a newborn which cries vigorously, good tone.
Okay, there is a series of first one was birth weight. Birth weight is between 2.5 to 3.5 kg. Term child, so 37 completed weeks of gestation. No major malformation is present. And birth weight, it should be AGA, birth weight is between 10th to 90th centile. Fine. And there is absence of any maternal illness or any high risk features in the mother, with UGR scores being normal, and there is no postnatal illness in the newborn baby. That is a normal newborn baby. Understood? Now, fine. So you have declared that the newborn is normal. The baby is at 44 hours of life. Now the parents will come to you and ask for what? They'll take the child home, right? They'll take the baby home and they'll ask you for discharge, correct? So now what is the criteria for discharge? When do you, okay, and before discharging the child, what you have to know is the routine newborn care that you will provide to the child. There are 10 steps of routine newborn care. That also, like, you'll have to know each 10 steps, but that is too much into the theoretical aspect, so we'll not deal with it in detail. You'll have to know what the routine newborn care as well is. After giving this routine newborn care, after counseling regarding the breastfeeding of the baby to the mother and the family members, finally it comes to the discharge. No, so when do you discharge the child?
So after 48 hours of life.
Yeah. at around 2 to 3 days of life, we can discharge the baby, correct? So what are the criteria the baby has to meet to discharge?
So,
So a formal examination has to be done and declare that there is no congenital disorders and no abnormalities present. The screening test, one is red reflex and one more is for CHD screening, the pulse oximeter test has to be done. The newborn has to be immunized for both, for the 3 doses of immunization, 3 routine immunization should be given along with vitamin K. Mother has to be counseled regarding the breastfeeding, and you will have to assess the adequacy of breastfeeding in terms of the subjective and objective methods which we saw before. Okay, so if all these criteria are fulfilled and the child has not lost significant amount of weight, then the baby is fit for discharge. Now, okay, fine, you discharge the baby, what is the advice you're going to give to the parents?
so for exclusive breastfeeding,
Yes,
we
very
advise.
good. Yeah, so we counsel the parents regarding the exclusive breastfeeding. Then if at all the parents are taking the newborn baby at an earlier day, like at 2 days of life, then they'll have to get back the newborn child to examine for what? Neonatal jaundice. Correct? We'll have to examine for neonatal jaundice. We'll have to recall the child after 1 or 2 days. Then we'll have to tell the parents regarding one of the supplementation that has to be given until 1 year of age. What is that? Supplementation is vitamin D. Supplementation has to be given to all the newborn babies. That is 400 international units per ml. And finally, you'll have to explain regarding the danger signs that has to be present. And if present, they'll have to get back the newborn immediately for further care. So what are these danger signs? These danger signs can be if the child is irritable, if the child is not feeding well, child is lethargic, child is throwing convulsions, child is having fever, or child is the child is pale and hypothermic. So all these things are danger signs. We'll have to explain to the parents and get the newborn to the hospital. Okay. So I think so that's it, Charul. You have presented really well. Any doubts?
No, sir.
In the chat box, do we have any doubts? The YouTube. So any other doubts? Charul, do you have? I don't see any doubts in the chat box or YouTube.
No, sir. No doubt.
Okay, fine. So the case was really well presented, Charul. Good job.
Thank you, sir.
Yeah. So if there are no other doubts, I think so we can conclude the session then. Okay. So thank you, Charul, and thank you participants as well for being with us throughout the session. And if in case you have any doubt regarding the newborn history taking or newborn examination, along with video demonstration, we have already done the class and it is present in our YouTube channel. You can always go back and see those videos. Fine.
Okay, sir.
So yeah, thank you guys.
Dr. Ashray,